Question for Kiki. Given the rising costs of healthcare since the change in Holland, and given the evidence of increasing, say, co-payments, is there a rising public discontent about what is happening, or is there an increasing sense that this may become unsustainable and that yet more radical reform will be needed? Or is there a sense that it's not too bad and we will persist?
Maybe on the one hand, people in Holland are pretty happy because they get anything they want to, and most of the costs are hidden out of sight. If you pay earmarked taxes, you don't realize how much you're paying. So most Dutch citizens have no idea how much the total bill for health expenditure is. So I think that would dampen public discontent. However, what surveys do suggest is that the public confidence, both in government, but particularly in health insurance, has gone down dramatically. People used to feel they belong to a sick fund. They were a member of a sick fund. There was a sense of membership, and that's all gone. That's disappeared, and now they feel these health insurers are certainly not going to do anything to promote my own interests.
Thank you. Just a quick question. It's a very similar question to the last one, but it's in that sense of rising premiums, increasing co-payments. Even before we get to that point of public discontent, is there a concern with unmet medical need in terms of people choosing not to avail of medical services because of those problems within the insurance model? Because I think that's the concern here, is that we could introduce a whole new system and still in 15, 20 years down the line, people choosing not to avail of medical services or underutilising them because of the costs involved?
No. As of now, in the Netherlands are among the lowest of all OECD countries, and there are no co-pays for GPs. So in general, most patients in Holland have fairly good access to the basic health services they want.
Hi, Shane Hogan from the National Disability Authority. A question for Kika, and maybe just to indulge the audience, I asked the same question of some of the other speakers this morning, but is there any particular findings about impacts on people with disabilities of universal health insurance in Holland? The research we've commissioned would show some impacts around difficulties in switching or difficulties with having to make co-payments or cover additional excesses that other people wouldn't usually be facing. Just love to hear your experience on that.
Yeah, there are some of all those problems, but actually I would call them very minor. The big drama we've had is in the long-term care insurance that also covers a lot of services for disabled people is the cash benefit, the voucher system. We set it up with open doors, and that for all political reasons it's a story by itself, but we basically without any limits. So people could get up to 24 hours per day home services if they needed that, which was nice for patients, but could cost hundreds of thousands of euros for one person. And then finally we woke up and saw there was quite a lot of fraud in the system because it was very easy to apply. And once you had a voucher, it was easy to keep that. And the average amount went up and up and up and was something between 20,000, 30,000 euros. And that was hard to control. So now finally the Cabinet has been shocked into reality, but they now first announced they want to stop it altogether, and then there's a backlash because people have gotten used to it and they like it. But I think that's been dramatic, a dramatic zigzagging in course, and it particularly affects the younger adult handicapped people who want to live by themselves.
There's somebody down there.
Yeah. Hi, it's David Grannon's my name. I just had a query. Given that we're going to supposedly radically reform our system, is there a baseline study that's going to be done to measure how much, like per capita, that this costs? Like I was looking, as the speakers were talking today, I was looking at all the various costs on the 2007 statistics. You know, so Ireland, I think, was $3,000 per person. Norway was $4,000. I think somebody was talking about Norway earlier on. US was $6,000 per person, right?
These are old data.
Yes, this is 2007 data because I was just looking it up when I was. Yeah, it's old data, and it's that's PPP data. So obviously, and what they said was that was capturing public and private expenditure. Now, I was just looking at HSE figures as well at the same time when I was just on the computer there, and it didn't seem to me that the private expenditure might be being captured. So I was wondering if we're going to go and see, how much does this cost at the moment, and a really good study capturing all the private expenditure and all the public expenditure, and then we can come back in 5 years' time and see. And is there a level at which we say, hang on, this isn't working. This is working for the private sector. There's more money being made, but it ends up being perhaps a tax on the people in the country, because I have a funny feeling that it's a little bit like the shock doctrine. There's a crisis now, let's privatise a lot of things. I'd be a bit concerned about that. It seems to me that there are a lot of really good things that are happening from what I can see. But at the same time, especially from the last speaker, what you were saying, the system's only been in the Netherlands a few years, and the total cost, it looks like it is rising. So, I think a baseline study would be really good that we could look at again in 5 or 6 years' time, and decide a level beyond which, well, actually the old system was better. Is that in the pipeline? Is there, as part of the programme, is there a study that will tell us?
We know what our basic expenditures on cost on healthcare are.
Just to the HSE, or
No.
I mean everything private, what everybody spends.
Yeah.
Yeah.
We do. I mean, including the public and private system, we do. We have a breakdown of what percentage is public and private, and that's all published as part.
Right.
So, I mean, that sort of overall expenditure on healthcare, and if that was your basic metric to monitor, and if that was your judgment on whether this is effective or not, that data would exist, does exist.
Yeah, it was only, I suppose, from what Dr. Ukma was saying, is that some of the costs are hidden, that they are hidden, that people don't really know, like the people in the Netherlands don't really know where the expenditure is coming from. So if there are hidden costs in the Irish health system, as it were, I suppose that's what I was interested in.
Well, I think even when there are, when there's transparency about costs, not everybody would know them or would be kind of reading, the data. So, it's not necessarily public knowledge in the same way. Somebody down at the end here.
Hello, my question is for Dr. Ukma. Why did the Netherlands change from the system they had before? Now, I was vaguely familiar with the system they had before, knowing people who lived in the Netherlands when they had the previous system. I just wonder why they changed from it. Because it seemed to, I know there were anomalies, but it seemed to meet most people's needs, and it seemed to be cost effective.
Yes and no. The one political issue that may have been exaggerated, but it was a political issue, 40% of the population had private insurance because they were not eligible for social insurance. It was a bit awkward. So if your income would go up, you would no longer be eligible in social insurance, and you had to find private insurance, and then the private insurance wouldn't accept everybody, and then we had to develop regulations for that, and it turned out that private insurance were charging elderly people with higher premiums. We had to develop insurance for so the government regulation of the private sector became more and more extended and didn't work very well. In total, you can say Dutch people were pretty satisfied, the total system worked well, and moreover, the private sector more or less behaves properly as if it felt part of the public system. So, to answer the question why we went that road, I think the main answer you would find in a sort of ideological idea. The whole new public management idea, the idea that here finally we found a model that would promise painless cost control because it would take it out of the hand of government. It would offer choice to consumers, something, it's hard to be against choice. So it mixed all sorts of notions. It was never properly tested. It was just, it was developed based on a couple of those 4 assumptions I mentioned, framed by Alan Enthoven in the United States, although we didn't use him as the main source of inspiration for that. So the answer is not a direct and a clear answer why we did that.
Thank you. There's somebody down here.
I wonder if I could ask Dr. Ukma about up-to-date information from Australia. It's about 2 years since I've looked at it, particularly for laboratory testing, because their definition of eligibility and of groups was extremely sensible. and it didn't force people to take very strict protocols and treatment, but it did certainly regulate against overuse.
I can be very brief. I don't know anything about laboratory testing in Australia. Sorry.
Yes, I'm just taking this question from somebody down there. I think
my name is Margaret Barry, and I'm fascinated at this stage of the day by coming back to the question of ideology, because I think underlying everything today has been an assumption about the value of equality and an assumption about a reform programme that's been designed without the detail that's missing is in the money. And I think there's no reform without looking at the ideology that drives how funds are raised and spent, because I think that's where you get the expression of what people actually believe. And I suppose I'm left with this comment this morning that when in Ireland we've had the opportunity to go for universal anything, we've generally gone away from it. And I think there's a danger here that we're talking about the idea of a health reform, as if somehow we're turning towards a universal system and the value of equality, when I don't think in health there's any evidence that that's what we actually believe. And I'm really struck by the amount of work and thought that's going into all of this, and I think it would be really, really valuable to put this ideological question more to the heart of it in terms of what do people actually want to achieve. Because I've been thinking this afternoon that an awful lot of what's been said today is paralleled in the education system, where we have a 2- or 3-tier education system. We have happily a 2- or 3-tier health system. We have happily inequalities all over the place. And I'm not sure what's either in our elected representatives or in the way we manage ourselves generally, that there's evidence that we value social solidarity, which I would be interested to ask you, because I would assume that has been characteristic of the Dutch people for a long time, is a sense of social solidarity, which I think we really don't have here. I'd like to see us study that as much as the mechanics of how we express it then in health.
Thank you. I'd ask for a quick comment, and then we'll wind up from the speakers. I know, Sinead, would you like to?
I would agree with you.
I would take it as a comment. I have much to say other than that, as part of the programme for government or part of the manifestos of the political parties, some of what you've just outlined and what's now before us in terms of health reform is very clearly stated. We voted for it.
True. Right.
I think your question about ideology is a really important one. I think the expression of ideology is reflected in the principles that are set out and the values that inform the type of health systems we have, the type of education. And I agree with your point around social solidarity. We don't have a strong history of that in this country. But I think in terms of, we have been talking a lot about equality, and I think there is an opportunity with the current crisis and the time of reform that has almost been forced upon us to try and ensure that we actually try and embed that as best we can. Thanks.
Thank you. I'd like to thank all the speakers for their contributions, and I'd like to ask Professor Graham to close the meeting.